Dr. Alexopoulos. It really is an honor, a pleasure to be here, and it's important for you first to note my disclosures because it's a lot of institutional support from multiple drugs and device industry. But most importantly, I want to be thankful for the opportunity to be here at this symposium, and I'm sorry for all the people who are sleeping at home and didn't show up, because I think this has been one of the best courses I have been to, and I'm just most grateful to the country of Greece and Athens and this beautiful country, and the fact that it's been bestowed upon me now as part of my life as well, because of the fact that I've been lucky enough to enter into Greece as a Greek now with my husband, Dr. George Dangis. So it's a fantastic opportunity to be here. So yesterday we talked a lot about stroke after TAVR. Today we're going to talk about this balance of bleeding and ischemic events in a patient who presents and needs a TAVR. So we first consider the thromboembolic events in these patients. This is not a small issue. And it's a various numbers of things that we have to think about in a TAVR patient. First, acutely within the procedure, we as the people who perform those procedures want to avoid all of these important acute complications. We want to get our valve in, we want to get the best possible result, but we want it to be completely free of the important complications. But it is no question that there is a tremendous amount of thromboembolic burden on these frail, old, high-risk patients. So acutely within the first day, we are absolutely looking at these important complications. Then there is that subacute phase. We think, oh, we're out of the woods, but actually in the next 30 days, anything that happens, it's still a procedural, a acute, subacute complication that gets counted. And so things like New-Onset AFib, aortic regurgitation, especially the stroke, that you can think about the milieu of stroke. We talked a lot about that yesterday. And then beyond 30 days and then down the line, we start thinking about very important issues. And each and every one of these for thromboembolic events and the different etiologies are facing us towards the one common factor, this whole idea of atrial fibrillation. And we'll talk about that and how it is a nidus for stroke and thromboembolic complications down the line. But let's not forget, I've listed stroke, disabling stroke, TIA, systemic embolization, DVT, New-Onset AFib, myocardial infarction, coronary artery disease requiring intervention, and then of course cardiovascular mortality. But the number one of the most common things that happens actually is life-threatening bleeding. So we as clinicians, the majority of these patients really are high risk for bleeding. And when you think about this, both of these are playing a role at the same time. Take a look in the first 30 days where all of the complications that get counted are about our procedure in that whole new first area, both bleeding as well as the cerebrovascular thromboembolic events are quite high. And then as you go down the line, these other issues come into play. So it's very, very important that early on, we're very much walking this tightrope between bleeding and thromboembolic events. And what are we supposed to do? What should we do to avoid these thromboembolic events? And we're thinking about antithrombotic, anticoagulation, and then what is the best possible way for us to proceed? Well, I can tell you that the trials are few and far in between, and none of them are perfect. None of them, even including the ones that we designed, that I personally was involved in. So when we start with the ARTS trial, this was a aspirin versus SAPT versus DAPT, aspirin versus aspirin plus clopidogrel in patients after an aortic valve replacement. As you all know, when these trials came about, because it was stent-based technology, the valve was attached to a stent, DAPT was given 3-6 months, something like that. So here, only 222 patients randomized to a single antiplatelet versus a dual antiplatelet, and then only a 3-month follow-up. So really, these are not the kinds of trials we're used to in DAPT, right? We're looking at thousands and thousands of patients, but given that, what they did find certainly was no big evidence for any kind of a improved outcome in patients with dual antiplatelet therapies. In fact, there was more of those events, and if you put the net events together, which also is not a great thing to do, ischemic and bleeding events together, it was negative for these patients. So it was worse, but obviously not reaching statistical significance. It's really not underpowered, not the right study. And if you look at it was really both bleeding and stroke being in the wrong direction for the dual antiplatelet therapy arm. And so hence it added it to be negative. But still, if you think about this, we're underpowered. I still wouldn't say you can go to a single antiplatelet regimen. But the best we could do when we have underpowered studies is, let's say, combine as much as we can. And guess what? We came up with, Davide Capodanno came up with 421 patients, still incredibly underpowered. And even so, you start to see that bleeding is in the wrong direction, as it would be, because these are really frail patients. We're going to hear a lot about this leaflet, thrombosis. I'm not covering any of it at all, but let's not forget that these thromboembolic events are also incredibly important. So what will win is one that we do not know. Where are we with the current recommendations? Really no great recommendation. In the US, we have this 2B, which is, 2B is like to be considered, so really, and the level of evidence is like C, really, literally, with no real clear evidence of what to do for these patients. But patients who do not need oral anticoagulant at the moment, anticoagulation to achieve an INR of 2.5 could be reasonable, and clopidogrel also could be reasonable. So really, no clear evidence whatsoever on what to do. And then, of course, with no specific recommendations at all for those patients who need oral anticoagulation. So really, really difficult thing to do. So to better understand this, especially given this situation of the leaflet thrombosis and the thromboembolic events, and in the light of everything that we were talking about with a stent-based approach and understanding that there could be some benefit of an oral, low-dose oral anticoagulation in these patients, the Galileo trial was designed, 1,500 patients, rivaroxaban at 10 milligrams a day, still a high dose, but actually, if you think about it, the pharmacodynamics or pharmacokinetics show about a 2.5 milligram BID. This is the QD. It gives you basically the same peak and trough with that 10 milligram dose versus a DAPT strategy. And then the patients would be followed. As you all know, the trial was stopped prematurely after the patients were enrolled, but stopped by the DSMB. So we will hear those trial results, hopefully due to safety, and that was for increased both bleeding and ischemic and mortality. And this will be shown later on, hopefully this year. Where we are with the clinical trials, the Atlantis trial is interesting, looking at apixaban in a patient with 2 different strata. So it's looking at those patients who require an oral anticoagulation versus those who don't. And those who require an oral anticoagulation will be compared to DAPT versus SAPT. Those who require oral anticoagulation will be compared to VKA with apixaban. Those who don't, with DAPT versus SAPT. This is ongoing and continuing enrollment mostly in Europe and in France. Importantly, the POPular-TAVI trial, this one is, I believe, also another trial that is going to be very, very important, looking at patients undergoing TAVR, still stratification based on whether or not you need an oral anticoagulation, randomizing the patients who do not need oral anticoagulation to aspirin versus DAPT, versus those who do need it with an oral anticoagulant or an oral anticoagulant plus clopidogrel. This is ongoing, and we will hear those data. What about if there is AFib and TAVR? The prevalence is big. You need to think about these patients. It's 14% of what we know established, but New-Onset keeps adding, and asymptomatic, not caught, non-sustained atrial fibrillation or New-Onset AFib that is not been captured could probably happen in these patients. Once there is pre-existing or a new-onset atrial fibrillation, the entire trajectory of the outcome of these patients change dramatically. Increased mortality, increased all kinds of absolutely negative results, increased stroke, all of those things. So incredibly important. And if you actually look at predictors of post-TAVR events, new-onset AFib is an important predictor, as strong as a chronic atrial fibrillation. In fact, new-onset AFib is even a stronger predictor. So it is a very, very important issue in these patients. So what are we doing? What are some of the trials? I talked to you about the ones that are ongoing. There's another trial here where in a patient who has atrial fibrillation, there is undergoing transfemoral approach. This is another apixaban study where you stop the VKA and then you basically have a randomization of only about 300 patients, 30 days and 1 year follow-up. And this trial actually underpowered for a lot of the important endpoints, because as you know, the bigger trials are underway, but the 30-day outcomes look to be in the right direction for the novel oral anticoagulant apixaban. But the largest study in AFib patients is against edoxaban with Professor Van Mieghem and Professor Dangus as the two co-PIs from US and Europe. This is 2,200 patients with AFib requiring an oral anticoagulation, randomizing to warfarin versus edoxaban at 60 milligrams per day. And the patients are being followed with a 12-month primary endpoint. The study is already enrolled and randomized over 1,400 patients, and this is doing excellent. So if you're a site, please give us patients. We need it. So this is sort of what's going on right now. There's an aggressive amount of numbers of post-TAVR studies that I went through, and I didn't even tell you about the Watch TAVR, this whole combination of left atrial appendage closure with TAVI studies. Very quickly, coronary artery disease and TAVR, we already heard a high incidence, an important incidence not just in the trials, but also in the registry. About 75% of the patients, 65% of the patients will have some coronary disease. If you have coronary disease, this is a predictor of mortality, and in fact, one of the most important predictors as you look, if you go through the meta-analysis, coronary artery disease, existence of it, predicts that patient's mortality, puts them at a much, much higher risk. The gold standard right now is coronary angiogram, but what we do not know is that when you find coronary disease, what are you supposed to do? Are you to go after that lesion immediately? Are you to stage it? And if you look at this between doing PCI at the same time, around the same time, versus staging the PCI, the 30-day mortality and life-threatening bleeding is no different. Neither is the vascular site complications, but renal failure and contrast volume use will be worse if you stage the patients. So at the moment, we have this very, very big conundrum of what to do. Here's a very nice diagram or algorithm. If there is obstructive coronary disease, see if there is a large area of myocardium at risk. If there is, then go forward and do the PCI first and then move on to TAVI. And then in those who have moderate or non-obstructive, first do the TAVI, then you can go and do functional assessment of the CAD. And then, of course, in those patients who have a small area, only use ischemia-driven revascularization. As we already heard in the beginning of this session, activation trial is underway. There are only about 310 patients, but they are looking at these different algorithms to really randomize them to PCI versus no PCI. I think it's going to be very, very interesting. So just quickly, you already heard TAVR, AFib, oral anticoagulants are a must. The question is, should you switch to a lifelong of novel oral anticoagulant, especially if the CHA2DS2-VASc is high? If there is a recent coronary stent, I think right now we're really dropping the aspirin. Triple therapy is totally out in these patients. And then the pharmacotherapy is to really get rid of that aspirin as much as you can, just to go to a single. And of course, in those patients who don't have AFib, the jury is out. We really have no idea. And right now, Dr. Dangas has designed a very large randomized study, Chloe, through the NIH. We'll see if we get funding for that. But short of that, we're very, very far from the answers. So AFib and CAD, major comorbidity in those patients who have TAVR. So we've got to pay attention to it. The chronic AFib, but also new-onset AFib, as well as if you capture AFib down the line, important predictors of the adverse outcomes. So let's make sure we pay, again, a lot of attention to those patients. Unfortunately, the scientific evidence on the choice of the best antithrombotic and anticoagulation regimens in the patients undergoing TAVR is absolutely weak. Let us not follow what's going on in the stent world, that we still don't know what the optimal DAP duration is on our patients after stents. 2-3 decades later, we need to find out the answer here. And so stay tuned for the results of the current ongoing trials, although I don't think any of them are completely powered to answer all the right questions. Thank you so much for your attention.
Thank you very much, Susan.